All right, welcome to today's explainer, where we are heading straight to the wards for some clinical rounds. For this one, I want you to step into the shoes of the attending physician, and I'll be your highly enthusiastic resident presenting a seriously fascinating case. We're going to follow a single patient's journey to really unpack the mechanics of acute pancreatitis, and then we'll contrast that with chronic and autoimmune presentations. It is just a fantastic masterclass in clinical reasoning, from normal physiology right down to bedside diagnosis and management. So grab your coffee, docs, and let's go round on our patient.
The worst pain of my life. That is exactly what our patient said the second she hit the emergency department doors. And as clinicians, we hear about pain all day long, right? But when a patient tells you it is literally the absolute worst pain they have ever experienced, well, that demands your immediate, undivided attention. She's got this sudden, severe, band-like pain right in her epigastrium, and it is radiating straight through to her back.
So let's build out her clinical picture. We've got a 46-year-old woman, history of obesity, and a strong family history of gallstones. She actually tells us that she's had similar, though much milder, episodes of right upper quadrant pain after eating heavy meals in the past. Classic biliary colic. And here is a phenomenal physical exam for all. She's sitting straight up on the stretcher, totally leaning forward. Why? Because lying flat makes the pain completely excruciating. So right off the bat, her female sex, her weight, and that prior biliary colic drastically shoot our pretest probability of a biliary cause right through the roof. Let's think about the anatomy here for a second, just to orient ourselves. Picture the plumbing. The common bile duct coming down from the gallbladder merges directly with the main pancreatic duct. They literally share common plumbing right before they empty into the gut at the ampulla of Vater. And honestly, that shared real estate, that is exactly why our patient is in absolute agony right now. Okay, before things go wrong, we kind of need to understand how they go right. The exocrine pancreas is, for all intents and purposes, a factory. It produces these highly destructive digestive enzymes. But to stop from just digesting itself, the pancreas normally packages these enzymes as inactive proenzymes, we call them zymogens, and stores them safely inside the acinar cells. They travel securely down the duct and remain totally inactive until they hit the duodenum. That's where an enzyme called enterokinase finally flips the switch, turning trypsinogen into active trypsin.
But because of her history, we know exactly where the mechanical failure is happening here. A gallstone has traveled down the biliary tree and lodged firmly right at that shared exit door, the ampulla. With the outflow totally blocked off, the pancreatic secretions literally have nowhere to go. Ductal pressure rapidly shoots up, and all those inactive enzymes start backing up into the gland itself. When that exit door is blocked, the downstream effects are just catastrophic. The protective brakes fail completely. We get this premature activation of trypsin right inside the acinar cell, instead of out in the safety of the gut. That active trypsin then goes rogue, activating all the other enzymes, and it triggers this horrific self-amplifying cycle of autodigestion. I mean, the gland is literally eating itself. This leads to severe local inflammation, massive edema, and if we don't check it, a systemic inflammatory response syndrome, SIRS. It's a full-body alarm state that can absolutely cause multi-organ failure. Which brings us to the formal textbook definition. Acute pancreatitis is an acute, reversible inflammation of the pancreas caused by this inappropriate enzyme activation. Now, I really want to emphasize the word reversible here. While this can range from a totally mild, self-limited disease all the way to a necrotizing, life-threatening nightmare, the baseline architecture of the gland can recover once the acute attack resolves. That makes it distinctly, fundamentally separate from chronic pancreatitis, which we'll get into in just a bit. So, how do we actually confirm this diagnosis for our patient? We aren't just guessing. We have strict criteria. To officially diagnose acute pancreatitis, you need any two of these three things. Number one, that characteristic epigastric pain radiating to the back. Number two, a serum lipase or amylase that's elevated to greater than 3 times the upper limit of normal. Or number three, characteristic findings on cross-sectional imaging, like a CT scan or an ultrasound. Speaking of those enzymes, let's talk about the timeline of amylase versus lipase. They both spike pretty early in the disease, but clinicians almost always prefer lipase. Why? Because lipase stays elevated way longer than amylase, which can actually fall back down to normal in just 3 to 5 days. Plus, lipase is a lot more specific to the pancreas. But please, if you take nothing else away from this, remember this absolute can't-miss clinical pearl. The actual number of the enzyme elevation does not predict how severe the disease is. A lipase of 5,000 does not mean your patient is inherently sicker than a patient with a lipase of 1,000. Now, our patient has the classic pain and a profoundly elevated lipase. Boom, we already have our two criteria. We don't technically need imaging to make the diagnosis itself, but we definitely need it to confirm the cause. So we ordered a right upper quadrant ultrasound to hunt for gallstones. And sure enough, there's a bright echogenic stone sitting right there in the gallbladder, casting a very prominent posterior acoustic shadow behind it that entirely cements our biliary etiology.
All right, we have the diagnosis, we know the cause. Next step, prognosis. Is she going to have a mild course or a severe one? The BISAP score is fantastic for this because it's so simple and you can use it right in the first 24 hours of admission. It looks at BUN, impaired mental status, SIRS criteria, age over 60, and pleural effusion, 1 point for each. Our 46-year-old is perfectly alert, her BUN is totally normal, and she doesn't have SIRS or any effusions. So, with a BISAP score of 0 and 0 evidence of organ failure, we can confidently expect a mild clinical course. Since we're anticipating a mild course, we immediately initiate 4 early management pillars. First, moderate fluid resuscitation with lactated ringers. Notice I said moderate. We want goal-directed hydration here. We do not want to drown her in fluids. Second, early enteral nutrition. The old school days of keeping these patients strictly NPO, yeah, those are gone. If she can tolerate food, we feed her. It keeps the gut barrier intact. Third, we manage that severe pain with opioid analgesia. And fourth, we treat the root cause. This is gallstone pancreatitis, meaning she needs a cholecystectomy during this exact same hospital admission, so this doesn't just happen all over again next week. Oh, and one more vital rule for the wards. We absolutely never give prophylactic antibiotics without confirmed infected necrosis. Sterile inflammation does not need antibiotics. So, our patient is going to do great. Her gallbladder will come out and her pancreas is going to fully recover. But let me put my attending hat firmly back on for a second and ask you, what happens to the patients who aren't so lucky? What happens when a patient suffers from recurrent acute attacks or maybe chronic toxic injury, and that reversible inflammation we talked about becomes permanent? And that brings us to chronic pancreatitis. Over time, those recurrent acute attacks or persistent insults lead to a heavy inflammatory infiltrate that eventually just lays down dense fibrosis. The healthy, functioning acinar and islet cells are permanently replaced by useless scar tissue. The exocrine and endocrine tissues are physically lost forever. But here is the crazy part. Overt pancreatic insufficiency, meaning severe malabsorption, and really brittle diabetes, that typically doesn't even show up until about 90% of the gland's function is completely wiped out.
If you're trying to remember the causes of this irreversible scarring, just think of the acronym TIG-R. Toxic metabolic is the most common, heavily driven by long-term alcohol use and smoking. Then we've got idiopathic, genetic mutations, autoimmune variants, recurrent acute attacks, and chronic obstruction. But listen, there is a massive clinical pitfall here with how these patients present. Often they have this chronic, totally miserable pain. But as the gland progressively dies off and turns into scar tissue over the years, the pain might actually start to fade. An absence of pain in these patients is absolutely not reassurance. It usually just means the gland has completely burned out.
So we've covered the acute emergency, and we've covered the chronic burnout. But let's shift gears for one final, incredibly high-stakes clinical dilemma. Imagine a patient comes to you with painless jaundice, and their imaging reveals a dense mass right in the head of the pancreas. I mean, every instinct in your body screams pancreatic adenocarcinoma, right? You start prepping them mentally for a massive, life-altering surgery like a Whipple procedure. But hold on, what if it isn't cancer at all? Enter autoimmune pancreatitis. It is the ultimate steroid-responsive mimic. There are 2 types, but both classically present on imaging with this loss of normal lobulation, which gives the gland a really swollen, smooth, almost sausage-like appearance. Type 1 is an IgG4-related systemic disease. It involves really dense fibrosis and often hits other organs too, like the biliary tree or the salivary glands, and it has a notoriously high relapse rate. Type 2, on the other hand, is strictly duct-centric. It has very minimal IgG4 involvement, is frequently associated with inflammatory bowel disease, and honestly, it rarely relapses. Now, because differentiating this from cancer is obviously paramount, we rely on the HISORt criteria to lock in the diagnosis. That combines histology, imaging, serology, other organ involvement, and honestly, most importantly, response to therapy. A dramatic, rapid response to first-line glucocorticoids where you literally watch the mass shrink and the jaundice resolve doesn't just treat the patient, it actually confirms the diagnosis itself. It is just a beautiful example of using a therapeutic trial to confirm your pathology. Which leaves us with this final thought to close out our rounds today. When you see painless jaundice and a pancreatic mass, the reflex is always to assume the absolute worst.
But by understanding the pathophysiology of the pancreas across its acute, chronic, and autoimmune states, you might just recognize the mimic, write a prescription for some steroids, and save a patient from a completely unnecessary surgery. So the ultimate question you always have to ask yourself on the words is, are you looking at cancer or a mimic just waiting to be discovered?